Okay. How many of you intend to have that in the near future? All right, well, good. A lot of hands.
Minimally invasive surgery or laparoscopy for that matter. So I'm not going to go through that, except to say that in Ghana, for example, early return to work is not necessarily an advantage. In fact, most people would rather not go back to work. But these are the advantages. But in spite of all that, there has been a slow uptake in many developing countries, including Ghana. Cost issues. Because you need to have training before that. And there are established training programs like fundamentals of laparoscopic surgery. It's expensive to do these. Although a country like Botswana did use it, but with trainers from Canada using Skype to train them. Otherwise, most people, I'm sure those with programs here have the same experience, have used their own means, if you like, with or without external help. So what is the problem? Now, mainly to do with cost issues. Training, you've got to train. Because the Australian model of see one, do one, teach one cannot be practiced here. And then equipment costs is always a problem. We have lack of maintenance culture and the cost to the patient. When we started, what we did was to charge the patient $1,000 more than an open operation. But with time, we've been forced to reduce the amount because patients are complaining they can't afford it. So it costs the patient. Then cost effectiveness, is it really cost effective? And sometimes it's difficult to demonstrate because the cost of a hospital bed is so cheap here that they can lie in bed for 1 extra week and it's still cheaper for them. So cost effectiveness can be difficult to demonstrate. And for the managers of our health institutions, there's competition for resources and they want universal access for healthcare basically. So they would rather not spend too much money there. But as we said, we need training. So I'll just go on straight to the simulated training. If you want to establish a training program, you must have objectives. What really do you want to achieve? And break them down to specific tasks, as well as procedure related. And I will explain that. But the essence is to make sure that people become competent. I took this from the Haiti experience, and if you see, you may not see from there, but they have basic tasks, and I'm sure we all do. Maybe just transferring pegs for handling or handing bits of pegs, whatever it is, from one hand to the other and so on. But you want to learn the basic maneuvers. You are testing hand-eye coordination. You are testing the ability to work in 3D space, but using 2D displays, things like that. And then you've got to assess based on maybe time, precision, and so on. And then with the specific procedures, so if you are doing, say, cholecystectomy, you want to, for each of the skills, you want to learn the necessary little skills that they need to maneuver. If you look at this one, which is also from Haiti, they're looking at, say, depth perception. We are trying to see whether or not. So somebody who constantly overshoots the target and swings, wild swings, very slow to correct, you score them maybe 1 or 2. If there's some overshooting, but they are very quick to correct it, you score them 3 or 4. And if they are very good, you score them 5. That's a type of thing. So it's structured and it measures what they are doing. So it's important to incorporate that. And the end is that they become competent in what they're doing. It's good to give a lot of time for practice. In Ghana, especially in Ops and Gynae, what they did was, after hours, the trainees will come back into the skills lab and practice as long as they want. You could also take home boxes, and I'll show some of them, that they can also take home and practice. But practice is good. We've already spoken about assessment, and feedback is important. It's important, sometimes you get to a point you tell the person, I'm afraid you cannot be a laparoscopic surgeon. So it's important. Because patient safety should be paramount. So what are the type of trainers that we use? Most of them are kind of tabletop trainers. They are safe, they are convenient, they are relatively inexpensive. They may not measure all the things really that you want to measure. But if you have a lot of money and you want to go for virtual reality, you can have more data. For example, you can even measure how much tension you are putting on the tissues that you get, and so on. But those are expensive. There are hybrid systems as well. But most of our countries, I'm sure, will go for tabletop trainers. So this is just an example. There are so many of them. So that's one, which is good. There are so many, but some of them are not too, if you like, user-friendly. But this one is good. Or you can make your own trainer. People have used card boxes and so on. Really, all you need is a box and some holes to put your instruments through, a camera inside the box. And in this one, as you can see, the person's laptop is there, it's connected to it. This one is by one company. They donated quite a few of these to us. So people can take them home. You fold it, like the box, fold it, take it home. And it has a camera inside, rather not a very Wi-Fi camera, but it's there also. And you can connect it to the laptop. So they can take that home and practice as much as they want. So I'll share some of our experiences we've had. To start, we needed to buy the equipment. And it's always difficult to convince hospital authorities to buy it. Fortunately, we had a fellow of this college who became CEO, and so he bought it for us. And then, but it was important once we bought it that those who supplied us should come and train. So don't just buy equipment, but they should come and train you on the use of the equipment. So they train the doctors, and it's important to train the nurses. So they did that as well. Not just handling them, but how to sterilize and all those things, how to clean it. And then we're ready to start, and we needed carbon dioxide. How do you get it? And it wasn't coming. So I collected a cylinder, put it behind my car, drove to Pepsi Cola, and got carbon dioxide, and we could start. So sometimes we've got to push. And then we started simulated training alongside some didactic lectures. The last thing we did, or we've done, is to incorporate lectures in laparoscopy to our medical students in their first clinical year, so that they get introduced to laparoscopy other units quickly got on board. So now urology, pediatric surgery, cardiothoracic surgery, and so on, are all practicing laparoscopy. What are the problems we had in setting up? It's inertia, and I'm sure all of you have experienced that from management, from colleagues and other people. Nursing staff, it's so important to carry them along with you, very important. I'll come back to that a little bit. And also consider sustainability issues. I will end up by looking at some of the pitfalls, and I've divided them into various. One is equipment. Salespersons can be a pain. There was one particular salesperson. I said, I don't want to see this woman again. I told the superiors, I don't want to see this woman again. And she had to stop coming to the hospital. But what equipment to buy? You may buy something expensive, but in order to afford, you may end up going for cheaper equipment that is not fit for purpose. So it's important to be careful. Or you may go for used or refurbished equipment that may work, but may not. The worst is to go for, and I've seen people do that, is go for equipment assembled from different sources. There's a gift of a camera here, there's somebody's refurbished monitor there, and so on, and try to assemble them and use. That can be very dangerous. Or you can go over the top and purchase things that you really don't need. So it's important to ask for advice. And also decide between disposables and non-disposables as well. Again, one will need advice to do that. Then who should be trained? I mentioned surgeons, obviously, but don't forget the nurses. It's very important. When I was in the United Kingdom, we had a laparoscopic nurse specialist who was trained to handle all these. And we found her so useful that we started organizing training courses for nurses. And many people send the nurses over to be trained as laparoscopic nurse specialists. And we tried to introduce this in my hospital in Ghana when we came. Don't forget anesthetists also need to be trained in laparoscopy. And then there's the support staff as well. Otherwise, in the middle of the operation, you may have to unscrub and go and fix something. This I call the system pitfalls. We had so much confidence in our electricity supply that we did not buy an UPS. Fortunately, we got away with it most of the time. Once we had to wait for 20 minutes for the lights to come back off when it went off. Otherwise, but we've learned our lesson. Then the other basic equipment, don't forget electrocautery, anesthetic machines, OR lights. Even the theater tables, you may find that you ask for a tilt of the patients, and then you find that, I'm sorry, this table cannot tilt, kind of thing. So you must have the system working. Others like autoclaving and so on. I've mentioned support staff already. Patient selection is important, especially in starting. It's so important. For me, for cholecystectomy, the most important one is, are the patient's symptoms due to gallstones? Because sometimes somebody is complaining of left iliac fossa pain. She has an ultrasound, he says he has gallstones, and they push the patient to you. And you may do the operation and find that the patient's symptoms continue. We did not have much problems with adhesions. In fact, most of the patients we started with had cesarean sections and so on, but they were not very bad adhesions. But patient selection is important because anatomy may vary and people should be fully aware. Operating under vision should be emphasized as well. And assistants should be well trained. Camera assistants and so on. This picture actually comes from Professor Dobe with this. I saw him working. This was in Lagos, where I had gone to join Professor Bode to organize a course. And you can see the trainee is very busy concentrating. The supervisor is concentrating, and the assistant, I hope he's not here. The assistant is really not interested. And sometimes assistants can give you seasickness, moving and twisting and rotating and so on. So they need to be well and adequately trained. The dangers of diathermy should be emphasized, poor vision and so on, equipment failure and so on. So it's important that in training we should incorporate all these things. I think that's my last slide. So in conclusion, we have said that the uptake of laparoscopy has been poor. We've given reasons why this has been so, and the importance of stimulated training. We cannot see one, do one, and teach one. So that is important. And then must be well assessed such that we have a competent surgeon at the end. Patient safety must be important. But no matter what we do, we should remember the environment in which we are working. People should be competent in open surgical procedures. Otherwise, when they have to convert, they will be lost completely. Thank you very much.
Thank you very much, Prof. Glante. Save your questions. We'll be able to get to them at the end. And also, I am very sure that Prof. Glante will be happy to get, if you can't get your questions here, you can email him or something and he can help you out if you're trying to start. So, the West African College obviously spans so many countries, and Anglophone and Francophone. Of course, in the spirit of our college, we have not limited our discussions to any geographical area. Our next speaker is actually going to be from our host country of Senegal. I was first in Senegal about 12 years ago when the college was held here at that time. And I was at that time quite impressed with some presentations.